Bismillahirrahmanirrahim. Assalamu alaikum everyone to Dentoscope Studio. We have started our live sessions by the renowned speakers all across Pakistan. And today we are honored to have Professor Dr. Arshad Malik Saab with us. He is a well-known speaker, both internationally as well as nationwide. He has spoken on so many forums internationally, and we are very honored to have Professor Arshad Malik Saab with us. He is a dean of HBS Dental College. He is the president of the Pakistan Central Council of Pakistan Society of Oral Pathology. He is the vice president and regent of International College of Dentists, and he is also one of our most respected teacher at Dentoscope Institute of Advanced Dentistry. Welcome, sir, to Dentoscope Studio.
Thank you.
Sir, today's session is about the basic principles of elevators uh, from surgical point of view, and I would like you to please share your experience and knowledge with all the viewers and subscribers.
Thank you. Thank you very much. I'm really very much thankful to you as well as a leader of Institute of Advanced Dentistry. You're really doing a remarkable job in Pakistan to potentiate the latest technologies and latest knowledge of dentistry in Pakistan. Ladies and gentlemen, I'm Professor Arshad Malik, and I'm recently I'm a dean of HBS Dental College, as well as I'm professor and head of oral and maxillofacial surgery department. Beside that, I'm enjoying the privilege of as a vice president of International College of Dentists Section 15. I'm regent of Pakistan and Afghanistan of my very renowned college, International College of Dentists. I'm country representative of World Laser Federation and ex-president of Pakistan Dental and Medical Association, Chakwar. It is my honor that I am being proposed by the Central Council of Pakistan Society of Oral and Maxillofacial Pathology as a president emeritus. Ladies and gentlemen, today our topic is uh, a renowned thing which a dental surgeon used to do in his daily practice, and that is dental elevators. And use of the dental elevator is really a skill, a technique, and an experience. It all becomes when you are very much aware of the dental elevators principle. Ladies and gentlemen, in this 1 hour talk, I'm going to cover all these 7, 8 points. And when you go for the history of dentistry, really approximately uh, 3000 BC, when an Egyptian Hassiri started dentistry as a separate subject. Then Aristotle in 400 BC, there were gentlemen who really gave the few basic principle of extraction of teeth. And it is approximately 100 years back when the Archimedes studies and described the principle of lever, which the in dentistry we used to prescribe very much. Then the ugly area and difficult areas when people used to do that extraction in a very miserable way. Ladies and gentlemen, in approximately 14th century, the devices by the name of dental plecon, they were introduced. And these are wedges like instruments which are being inserted within the teeth and beside the teeth to pull the teeth out. With this, the new advancement in dental plecon resulted in 15th century and 16th centuries. These plecon, they have power to engage the tooth in such a way that when you tight it and you just have the lateral pull, you are going to extract the tooth out. Then the dental keys get the entry into dentistry. This dental keys have the very different forms, and they are engaged within the tooth. And this engagement is like this: they are being trapped within the crown, and at the level of the cemento enamel junction, you pull it out like the physic forceps which we are doing these days in a very modern way. These dental keys in 16th century started. This is like that phenomenon like this, that you are going to pull the tooth by the movement of the dental key towards the side. In approximately 716, the elevator like hinge was introduced. It was a very good elevator, and it is, you can say that it is like a wedge principle it's used to perform. Then in approximately 1795, a punch elevator was given. It is look like that today's what we are using as a crier forceps. It looked like the crier forceps shape. Then a spade-shaped elevator in approximately 1800s, it was introduced, and it is really a very good elevator. It is like a winter's crossbar or like that. Then goat foot elevator, which is a resemblance to very much a couplant elevator. It was introduced in initial stages of 18 and start of the 19th centuries. Now, after having this small concept of the history, we must have the basic concept of the uh, tooth extraction. It is since to do extraction of a tooth without basic concepts of anatomy of tooth, anatomy of head and neck, oral physiology, diseases involving oral cavity locally or systemically, medicine used in dental surgery, and especially in neurosurgery, and basic principle of oral surgery. I think that these are the mandatory things before going for any extraction. Beside to these basic concept, you must have the knowledge of the anatomy of the eighth tooth, thickness of the bone, the vascular supply, the nerve supply, the orientation of the roots as well. For that purpose, you must get the concept of the curvature of the root, and you cut the root and see it from above. If it is like A, the elevator has a very good efficiency to remove the wedge type things very easily. Then, if you go for the B, that is one side concave, one side is a convex. That is one that this concave side engage a small piece of bone there. But when you see the ribbon-like effect like this, you see that one piece of bone is engaged here, one piece of bone is engaged here of the alveolus. And when you want to extract this tooth, this will be a hindrance right here in the ribbon effect. With the angulation, you have to use the elevators with reference to the angulation of the teeth. The angulation of the teeth is, you see, as you move forward, the angulation come on the facial view. When you go forward, backward, you see that the angulation become more wrinkly. That's why as you go backward, the extraction of the tooth towards the lingual side become ease, as the external oblique ridge is very thick on the posterior side, and the internal oblique ridge or myelohyoid ridge will become not so thick as compared to that of the external oblique ridge. So the extraction on the posterior side, if you move toward the lingual side, that will be more easy. Same the concept of the curve of Spee, that you must have a vision that posterior teeth are slightly below level, and the anterior teeth are slightly higher level. So the vision, as you go back, the visions become difficult in the posterior teeth. When you see the curves of Wilson, you see the same thing, but it is like here, that uh, these things are like here. You see that this curve of Wilson is that the teeth are mesially inclined in the distal area. So extraction of the teeth in mesially inclined is very easy. Then is the furcation. Furcation is the area between the roots of the teeth where the root trunk divides into separate roots. Now, how many furcations are there? According to numbers, it will ease you or it will make you the difficult for the application of the elevators. And if the multi-rooted tooth is there, Then the furcation, if it is deep, then it become more difficult. When it is up, you are going to have the ease in extraction of the tooth. Then the root assessment, use of the radiograph, that is mandatory, especially for the coronal level, that is enamel pulse, and especially in the root level, that is hypercementosis, ankylosis, dilaceration, concretion. These are the things which are very important when you use a radiograph, and you are going to have a mind that how I am going to extract the tooth. Now, after having these basic concept in your mind, you come to the elevators. The dental elevators, they have three parts. One is called blade, then is shank, and then is handle. When we go for the handles, they are different found in the market. You see those so many types of the handles they are available. They are made that it should be comfortable, and you can hold the beak of the tooth in a beak of the elevator in a very comfortable way. To deliver the sufficient pressure, designs as a flat T shape or a different round, and you are going to have the serrated handles so that the grasp should be very strong. These handles are actually made just to facilitate the person to exert the lever, or a wedge, or a wheel and axle principle in a easy way. Shank is that part which unites the handle to the blade. It transfers the forces from the handle to the blade. It should be very strong, it should not bend, and it should bear the forces which you are applying to the beak. The beaks, you see, they are different types. It transmits the force directly to the tooth or the bone. They are straight, they are triangular planet shape, or they are pick type. These are the different beaks. These different blades or beaks, you say, that these actually designed according to the requirement of the exodontia, root curvature, root placement, anatomical location of the root apex. These are things which we will discuss right now. These designs are made. Ladies and gentlemen, after having the parts of the dental elevator, now what are the rules for the use of the elevators? The rules are fulcrum, finger gaps, force control, and the control of inevident forces. The fulcrum should never be to adjacent tooth, because if you are going to place the force on the adjacent tooth, you are going to break you are going to break this portion of the tooth, of the adjacent tooth, or you are going to have the crack of this area, or you may have the concussion of the roots of the this adjacent tooth. So the fulcrum should never be adjacent tooth. And this is another thing very important to understand, that when their teeth, they are united with each other and there is no gap in between them, don't use the elevator in that area where is though no place for relaxation of the forces of the elevator. Never use the buccal or lingual plate as a fulcrum. You see, this is absolutely engaging the buccal plate. This place is never recommended for the use of elevator. The place is this area, or this area, which is a triangular area between the second tooth and the tooth to be elevated. This portion at the angle is the recommended area for the fulcrum, not the mid of the uh, then is the finger guard. The finger guard is very important for the holding of the forceps. These always use the finger guard to protect the uh, elevator slips. So this is initial stages when the students are in third year and fourth year. This is very difficult. Initial stages, they are not used to use the have the beautiful grasp of the elevator, but that is very important. It gives you a perfect control, perfect rotation, as well as your own control of the arm, that how much movement you are giving, that gives the movement by the finger guard. Next is that you use the force control. The force control is be certain that the forces applied to the elevators are under control. If your forces are not under control, what you are going to do? The elevator should be slipped away, and the elevator tip may not exert the correct pressure in the correct direction. So the force should be controlled. It should not be without. That's why we say that the finger control must be every time there with the elevator. Now, then is the control of the inevident forces. For that purpose, you must not to engage the root of the adjacent tooth and thus inadequately inventory, forcing it to be avulsed. If you are going to exert any force to the adjacent tooth like this, you are going to pull this tooth out as compared to you are going to have for the your principal tooth to be elevated. For that purpose, this is the placement of the beaks. You see, if the elevator is placed like this, that the peak of the elevator is bigger than that of the curvature of the root, these two edges of the elevator beak will hurt adjacent tooth. Now, second is the 2 point touch. This elevator is smaller one, and that's why the whole portion of the elevator is not touching the surface of the root, but it's 2 points only they are certain. You will see your so many elevators that they are blunted at these corners because they are not placed properly, and they are 2 points touch always given, and that's why it delivers only the points touch. And that's why sometimes you see that when you are applying the elevator in such a way that is only two touch point, you may have the crack of the tooth, you may fracture the tooth by these 2 points. The best and ideal one is the placement of the elevators in such a way that the whole the body of the tooth is involved and engaged. Now, after having the use rules of the use of elevator, we go for the indication for the use of elevators. Now, what are the indication? The indication for the use of elevator regarding to the removal of tooth and regarding to the removal of root. With reference to removal of the tooth, one thing is impaction, inability to use forceps due to abnormal location or position of the tooth. Say you are using an elevator. If we go for the Winters classification, and a white line is at the occlusal level, umber line is on the alveolus, and the red line is perpendicular to where you want to apply the forceps elevator, and that point is if it is too deep, then you are not going to use the your forceps at all. You are going to use the elevators. For that purpose, you may go for the Pell and Gregory classification, and you will see that whether I can use forceps at this location or not. If not, you are going to use the elevator. Mal opposed to crowded route, impossible to play the forceps and applying the forceps and giving hurt to the adjacent tooth. It is very much what is the photograph right here. You see that it's very difficult to apply the forceps here, and you can apply the elevator very nicely here. Then is the decayed teeth, when doubt that the crown will be fractured, decayed to like the glossy caries tooth, that endodontically treated tooth, any tooth which is under the fire of osteoradionecrosis, any tooth under the fire of osteopetrosis, there may any Paget disease, then there may be any tooth in the fibrous dysplasia area, any marble bone disease like what you have osteopetrosis. These diseases, when there is a teeth is very much engaged, and callosis of the teeth, hypercementosis, these are things which we will discuss later on. Tilted teeth, when application of the force is difficult, like there is the photograph I have inserted now. Now, removal of the tooth and removal of the root now. Removal of the fractured at the gingival, middle, or the apical third of the root, left in the alveolus, from the previous extraction. That is the indication of the use of the elevator. For that purpose, you see, this is one of the indication of the use of the elevator. This is very difficult to apply the forceps for these type of extraction, and you are going to use the elevator. If this is the teeth and you are going to extract it, that is better to use the elevator for these. This patient is a lupus erythematosus, and this patient has got the so difficult extraction. Now, this is the hypercementosis. It's a very difficult to go for the extraction of these tooth. You have to go for the surgery. You have to furcate the tooth, as well as you sometimes you have to furcate the area of the root as well for the removal of these things. Then it concretion. This is the union of the adjacent teeth, cementum by trauma, and these all teeth become one unit. If you are going to apply any of the forceps here, you are going to not going to extract the tooth at all, but you are going to fracture the jaw. Then there is supernumerary roots, sometime available in multiple, and especially in the area of the canine and premolars, you will find the extra supernumerary root. And for that purpose, you must be careful. And that's why we say it is mandatory to get the radiograph before extraction. Ladies and gentlemen, the dentine dysplasia is one of the indication of the use of the elevators. I don't think that you are going to use the elevators without any what you say reservation for the dentine dysplasia. This is very easy to go for the extraction of the teeth in dental elevators. Then is the dentine dysplasia, especially when W-shaped roots are there, and you can go easily for the extraction of these teeth with dental elevators, especially when malapose teeth and embedded teeth, impacted teeth, and you are going to use the elevators. And after the sectioning of the tooth, you can get the elevator very easily. Ladies and gentlemen, in danger of the use of the elevators is damaging or even unwanted luxation and extraction of the adjacent teeth. That is why the use of the principle of the exodontia is very important, and especially with reference to elevator. Now, fracturing of the jaw is one of the very big complication. Especially, I will say that when there are vertical impaction, you have the should be very careful for applying the wedge principle, and especially lever principle in the vertical Pell and Gravity class 3 and level 3. Then is the fracturing of the alveolus. If you are placing your elevator right on the alveolar bone, not at the interdental area. Then the slipping and plunging of the elevator in the soft tissue blood vessels, especially inferior alveolar nerve, or you are going to push the elevator into maxillary antrum, and that is creating the oroantral communication. Forcing the fracture root fragment into maxillary sinus, inferior alveolar canal, or some maxillary pterygomandibular space, especially through the lingual plate. When you are extracting the lower eight, you can push this tooth into the pterygomandibular space on the lingual side. Ladies and gentlemen, after having the concept of the these things, now we are coming to the mechanical principle of the elevator. The mechanical principle of the elevators are three. One is lever, wedge, wheel, and axle. Now, we're coming to the wedge, lever. Lever is a class 1 lever. You see, this is a short arm, long arm, and on the long arm we are effort, what you say, that we are placing force. On the short arm we are placing the resistance, or the but the job we are going to perform, that is by the short arm. So fulcrum is in between. When we talk of the lever principle, it is the simplest machine used to change the direction of the magnitude of the force. The lever is the first class lever. In the lever first class, the position of the fulcrum is between the effort and the resistance. That means one side is the effort and one side is the resistance, and center is the fulcrum. The effort arm, the long arm, on one side of the fulcrum must be longer than the resistance arm, short arm, on the other side of the fulcrum. That means that where your hand is, it should be a long arm. and where the beak is placed, it should be a short arm, and in between that the fulcrum, that is the bone, it should be nearer to the short arm. So that is the formula. Resistance into short arm is equal to long arm into effort. And that is the mechanical advantages. That is the long arm over short arm, or resistance over effort. And that is the mechanical advantage. The example is the crane pick elevator. Ladies and gentlemen, this is the crane pick elevator. This is the long arm, that is the fulcrum, that is the lateral side of the bone. This is the you make the slot, and you put the long arm down, and this short arm pull the tooth up, and that is the fulcrum. That is the lever principle, that less long arm less force, short arm great force, and that is the what the lever principle is. And it is the best. We have the crane pick elevator, which we give the slot in the tooth and we pick it up.
You shove
Like
deeper.
this.
Twist it again. Tooth will gradually come out into the back.
You see, in this, I play it again. I play it again. You see, he's inverting like this, and the lever principle, that there was a one spot engaged, and in that area we place the crane pick elevator. Now, wedge principle. Wedge is like a, what you say, a slanting mobile platform. That is the height of this platform, and that is the length of this platform. This resistance is moving on this length, that is I. It is length moving, and on the effort is pulling it down towards the height. The advantage is that as the height is lesser, you are going to get the maximum resistance, easy resistance to pull by less effort. As you increase the height, the resistance will be difficult to pull by the effort. You see, if the slanting, this slanting lengthy, the pulling of the resistance will be easy. But if it is short like this, it will be very difficult to pull it up. That means the long, what you say, the length, if it is more, and height, if it is less, you are going to get the maximum benefit. It is like this. Wedge is a mobile inclined plane which overcomes a large resistance at right angle to applied force that I have described you. The effort E is applied to the base of the plane H, and the resistance R has its effect on the slant, that is I, that is the length. Wedge are also movable double inclined planes, as two inclined planes placed at the base plate. You can use both sides as well. Sharper the angle of the wedge, less effort required to overcome the given resistance. And formula is the effort into inclined plane is equal to resistance into height. And that is the mechanical advantage. The inclined plane over height, the as big as inclined plane is, or as less as the height is, you are going to get the maximum advantages. And Coupland state elevator is the best example as wedge principle. That is the wedge principle. You insert the wedge, and the lateral side, you see the inclined planes. This is the inclined plane, and that is the effort, and that is the resistance, and this wedge is going inside. And the same in the elevator, state elevator. You say this is the height, this is the inclined plane, and this you applying the effort, and that resistance is coming out on this inclined plane. And this is what you say, the what you are implying, that is the inclined plane, that is the effort, and that is the resistance coming out from the wedge area. And that is what you see here, and we are inserting right wedge there at the end, and we are going to pull this foot out. The third principle is wheel and axle. And wheel and axle is like this. You see, this is the load, and that is the axle, which is coming from the well, and this axle is being rotated by this big wheel, and this small lady is pulling this whole wheel down, and that is the effort, and this is the load, that is resistance, and that is small is the axle, which is being getting the resistance, and that is the wheel which is being used for the effort. So after having this concept, wheel and axle is a simple machine being rely on a modified form of the lever. Effort E is applied to the circumference of the wheel, bigger one. The effort arm, RW, or the radius of the wheel, which turn the axle, the small one. The resistance, the radius of the axle, RA, so as to raise the weight resistance. That is the R. The formula is the effort into radius of the wheel. That means the bigger the radius of the wheel, you have to apply less effort, and you are going to get the more resistance to pull, or indirectly, as the axle radial, the small one, is less, and the resistance is applied to the less radius, you are going to get the maximum benefit. Mechanical is the resistance of the radius of the wheel oblique radius of the axle. Axle means small one, and wheel mean bigger one. As bigger as the wheel is, or as smaller as the axle is, you are going to get the maximum effort. The best example is winter crossbar elevator. Ladies and gentlemen, this is the example. You see, this is the radius of the wheel, and that is effort is applied to the wheel. This is the radius of the axle, and the resistance is applied to the axle. Now, that is the our elevator, and that is wheel going on, and that is the axle right here. This is the beak, and this is pulling up, and that is the small axle, and that is the wheel of the what you say elevator. That is the wheel, this one, and that is the axle, beak one, and axle is pulling the resistance, and that is the effort applied to the wheel here. This is wheel, handle is wheel, and beak is axle, and tooth is resistance, and your hand is the effort. Now, that is the how you apply the wheel and axle principle. That is the bone giving, and that is the small. This area is the axle one, and posterior where you have captured the handle. That is the wheel one. Now we are coming to the designs of the elevator. The designs of the elevators are two: straight elevator, offset elevator. The straight elevators are used for the parallel application and vertical application. There are two applications of the straight elevators. The purpose of the straight elevator is expansion of the alveolus, evaluation of the mobility, dislodging the root tip fragments, and control sectioning of the tooth. These are the purposes of the straight elevators. Their design is their blade, shank, and handles are parallel to one plane. They are absolutely straight. The blade, they are concave on one side and convex on one side. And if you see the cross section, it look like a shoe horn. Blade have the sharp tip, then have the various width. Like you see Coupland, 2 mm, 3.5 mm, and 4 mm. Now, handle standard firm, heavy, pear shape, grab. These are the different types of the handle they are used in the straight elevators. The finger grips for the sensitive application, and the palm grip for the heavier forces. The maxillary pinch grips and the mandibular sling grip. These are used for the for holding of the straight elevator. Now, parallel application. The first was the what you say straightforward application. In parallel application, blade inserted and the mesial and distal gingival interproximal parallel to the root of the convexity concavity of the facing toward the tooth. That means the blade having the outer side is convex and inner side is concave. You are facing the concave side towards the mesial and distal gingival interproximal area parallel to the root. Force delivery should be parallel to the long axis of the root. This should be an absolute state, and which dilates the alveolus and displaces the root occlusally. In the rotation forces, you use the act to displace the tooth buccally, and that is the according to the force you deliver. That is vertical application. Now, vertical application, blade inserted at the mesial and distal gingival interproximal perpendicular to the tooth. The first was not perpendicular, but to the parallel to the area. Now, this perpendicular to the tooth, the concave surface oriented toward the root surface. Rotation and push forces. Both forces result into distobuccal displacement of the tooth, and it will act like a sometime a lever principle. Now, that is the state elevator application. You push it, and if you insert it in between, you are going to luxate the tooth buccally and superiorly. Now, these are the different state elevators. They are Coupland, Lindoleven, Apexo, Floor, State Selden, Bean, and White. And these are different beaks which I have shown you the cut area. It has the bigger beak. Lindoleven a very small beak. Apexo has more small peak. Floor are very small, and it is like a tiny pin. This is a State Selden has the bigger one. The Bane has the moderate one, and the White has the more curvature in elevated way. The best one is what we used to use in our daily practice, that is the Coupland. That is the Coupland elevator, and that we generally used to use in our say. These are the state of, these are the Apexo, which is very pinpoint. These are the Warwick James, and it's slightly flat, and that is State Selden, having slightly curve at the end. These are the elevators, and this is the wedge principle, which you use to use like this wedge movement, like this, and you elevate the tooth. And second, you use the lever movement, and it is like this. I play it again, please have a look. These are the straight elevators, wedge and lever movement. The first is the wedge that you see in between the area. You see it is at the corner, it is not in the center, and you just push it straight down. When you are moving lever, you elevate, preventing that there should be no any attachment to the adjacent tooth. That is the straight elevator, and that is how you elevate the light in the anterior aspect. You see, and you place the wedge, and you just elevate it. It is like this, and you go on elevating, and you will see that the tooth is out. This another example. You see, you place the wedge right in the anterior, say, go straight, place the wedge, and push the wedge towards the root, make a pressure, slight movement, going down into the root area in between the tooth, and then you will see if the tooth is conical, you just push it and this will come out. That is the conical tooth, and especially this is recommended for the 8. Now we have the different periosteal elevators which are used in dentistry from all to, but generally we use the maximum mold number 9 or Haworth. This is mold number 9. One side is like this, you point it, and second side is round. And this is used just to elevate the gingival area from the lingual side, from the buccal side. And that is mold number 9. Now, second type of elevators are called offset elevators. These offset elevators, they are to displace the tooth and the root fragment away from the fulcrum or elevator. What is the design of the offset elevators? The blade are oriented at right angle to the shank and handle. They are just at the right angle. Blade based on the wide, having various width, blade beaks, tapers at different shapes. You can have the triangular, you have round one, you have pinpointed. Sharp tip blades to engage the root cementum, and rounded tip or flat blades to act against the broad surfaces of the root. Different handles from like pear shape, crossbar, T shape, small flat or serrated flat, oval shape available for the comfortable grasp. There are two grasps, palm grasps that are pinch area, that is in the maxillary side. On the mandibular side, you use the sling grasps, and that is very important for the use of the offset elevator. Now, these are the offset elevator. The most famous one is the Winter's crossbar. These are also Cameron elevator, Apexo elevator, pots very recommended for upper eight, and then the crier. These are the offset elevator which are generally used in dentistry. And mode of application of the offset elevators are blade inserted at the buccal aspect of the alveolus to achieve the safe and secure fulcrum. A burr created purchase point or traction point is required to facilitate the application or to elevate the ortho. The force deliver is rotation force that in wheel and axle move the tooth or tooth fragment away from the fulcrum and the instrument, that is the offset elevator principle. These are the different offset elevators: Selton, Miller, Cryer, Apexo. They have the pear-shaped handle, flat handle, the Warwick, James, and Hospital pattern, and crossbar, a T-shape, are the Winter, Crane, Peak, Berry, Potts, and Meads. These are the different elevators. Just I have mentioned that these are available in the market in different shapes. Now, these are the elevators which you see that they are the different peaks, and that they are with a T-shaped handle. And you see the crossbar elevators are. This is the Winter's crossbar tip. And this is the flat handle, slightly curved, and you see the triangular tip of the Winter crossbar is right there. There are two types of winter crossbar. One is you see triangular shape, and second is slightly curved one. This is slightly curved one. Sorry, there is during photography. Yes, this is slightly curved one. These both are the winter's crossbar. That is what for the smart application, and triangular one is for the uh, hard application. Ladies and gentlemen, at the end, I am going to present a case which is, with the permission of the patient, I have displayed it. This patient has reported from Multan, and he has requested not to display his pen. And this photograph is placed with the permission of the patient. He's 65 and there is no medical problem. What happened to this patient? Actually, he has the facial burn with the acid due to any family problem. The person has thrown the sulfuric acid on his face, and he's blind. He has macroglossia. He has microsomia. Due to burn, there is much fibrosis, but the person which we were dealing were very cooperative. And in this case, he brought to us for the removal of last second and left second and last molar, having the alveolar abscess, and it was decided for extraction under local anesthesia when the infection subsided. When the infection subsided, we planned for the extraction. We are given the local anesthesia, and this is the visibility which, after the retraction of this much retraction, he cannot open more wider mouth than that, and we adjust the visibility of this area. Then, after that, we uh, applied the wisdom forceps for the extraction by retracting the sheet, but this was unfortunate that we had the movement resulted into crown fracture. After the crown fracture, it was very difficult for us for the visibility, so we're using our indirect vision by the mirror as well. The couplant elevator was inserted slowly, and wedge principle we have applied for every three route by very slow. It was very time taking, but we have gone for the very slow movement with the wedge. And lastly, we removed the uh, pieces by the wheel and axle principle by the pots elevator, and we removed this uh, second molar in three pieces and the last molar in one piece. And that is the post-operative X-ray we got, that we remove all the things in total. And that is the comparison pre and post uh, operative, and the person has left the surgery without any complication. This was slightly difficult case which I have presented before you. Ladies and gentlemen, uh, our object should be that try to cure, but that is sometime we relieve often, we care always, but not to harm. That is the best thing. That whole of the subject which I have delivered today is regarding the use of the elevators, their principle, their design, application of the forces, application at the side of the patient. And I have given you the live few cases as well, to just to give you the vision, the how to use the elevator. If you have any question, you can ask the question right in the comments.
Pakistan +9233.
Right, uh, uh, right in the chat box, or if you possible, you can. I will request to the organizer that if there are any question, I'm here to answer. Thank you very much. It is over to Professor
Thank you so
Rashid.
much. Thank you so much, sir. It was really a very informative lecture, and we are really honored that you took out such valuable time and shared your knowledge and your experience, your expertise with all the
Yes,
viewers. I am indeed very thankful to you, sir.
Professor Rashid.
Ji, sir.
Any question?
Sir, let me check from the chat box if there are any questions. Um, जी सर, एक क्वेश्चन सर कमेंट में आया है. The question is that, in your opinion, which is the best elevator to remove last one third of the route?
Actually, it is not a universal thing that you can apply any single elevator at the one third of the route. It depends upon the which tooth is there and which route is there. Bucker route has the certain different parameters. Palatal route has the different parameters, and the single routed versus multiple routed, they have the different parameters. If you can say the single routed is the best thing is the crane pick elevator. You just make a slot and you just put the crane pick elevator. That will be very easy to remove the single rooted. For the multiple rooted, you section the roots, and from one root to the second root, enter by removing the septas, and these septas will refer you to engage the broken portion of the adjacent root, and that is by either by you can use the Winter's class bar or Cryo elevator.
Okay. Thank you so much, sir. Thank you so much.
Welcome. At the end, if you like to have any comments, then I can uh, say that it is really a very good effort by Rashid, by you, to giving these type of free seminars to the public, to the committee, and really it is a very वो कहते हैं पैगंबरों वाला वलियों वाला काम है कि you are spreading the knowledge, and mashallah this credits go to you and to Dentoscope that you are doing this effort.
Thank you so much, sir. आपने हमेशा appreciate किया. You have always appreciated and supported me, my efforts, and the efforts of all team Dentoscope. I am really thankful to you that you had always took up time either to come here for a live session or जब भी कभी हमें online guidance की जरूरत होती है तो हम जरूर आपकी तरफ देखते हैं. तो thank you so much. आपने time निकाला.
Thank you very much. Thank you
Thank
very
you so
much.
much, sir.
Thank
Thank you,
you.
sir.
Thank you.
Allah Hafiz, sir.